affected with the HIV infection are the GI tract, the mitochondria, especially of the muscle, and the heart. Avocados, I love them. Fatty acids that are great for the heart, by the way. Superfood. I want to start off by talking about the pathology and the pathogenesis of the HIV virus infecting the CD4 positive T cell. A lot of steps have to happen. This is very important because it's going to show us why antiretroviral therapy is so important and so effective. We have GP120 on the HIV virus. That has to attach to the CD4 receptor. There also has to be the co-receptor coming into play, CCR5 or CXCR4. Very important. So once we have the combination of GP120 with the CD4 receptor, that induces a conformational change in GP120. That also allows GP41, the other glycoprotein on the HIV particle, to bring the membrane of the HIV virus and the membrane of the CD4 cell together. We get fusion. The HIV virus enters the cell, but it's RNA. We have HIV RNA. HIV RNA has to become HIV DNA before it's integrated into the host cell genome. For that to happen, the viral enzyme, reverse transcriptase, has to change the DNA to RNA. If that step is complete, we have another viral enzyme integrase that will insert the viral DNA into those genome. Once that happens, messenger RNA takes it to the cytoplasm. We have a polypeptide chain. That polypeptide chain has to be broken down for the HIV virus to become active, to become functional. The other viral enzyme to do that is protease. If that happens, and the virus becomes active and functional in the shorter peptide chains, it will bud with the cell membrane, becoming a new viral particle ready to infect more CD4 positive T cells. So HAART is highly active antiretroviral therapy. We have our nucleoside reverse transcriptase inhibitors, our non-nucleoside reverse transcriptase inhibitors, protease inhibitors, fusion inhibitors, and chemokine receptor antagonists. I'll talk more about the importance of the chemokine receptor antagonist later. That's where a lot of the newer research is and where a lot of the new target drug therapy is. So I went through the steps of the virus invading the CD4 positive T cell because this is why HAART is so effective. At any of those steps, our fusion inhibitors can block GP120, GP41, or even the CCR5 co-receptor, preventing fusion, very important. Well, the reason the virus, why don't we just use that? Why don't we just use one drug? Let's just use a fusion inhibitor and end it there. That's because the virus can mutate. And it can overcome these different steps and the drugs. So if that happens and we get fusion, it gets inside the cell. Remember, that RNA, the viral RNA, has to be turned into viral DNA. That happens from reverse transcriptase. Well, that's where the nucleoside reverse transcriptase inhibitors come in, and your non-nucleoside reverse transcriptase inhibitors come in. Your NNRTIs, they're directly going to block reverse transcriptase itself. The nucleoside reverse transcriptase inhibitors, they're actually going to stop the termination of the RNA becoming DNA. If all of those steps occur, then we have our integrase inhibitors, which is going to block integrase from integrating the DNA, viral DNA, into the host DNA. If that step happens, and we're out here with the polypeptide chains, we have our protease inhibitors to prevent those polypeptide chains from being broken down into the smaller particles that are functional, that are active. So a lot of the new research are on your chemokine receptor antagonists, especially CCR5. Remember, CCR5, let me go back to that picture. That is the co-receptor. CCR5 co-receptor has to be functional, has to be active for the HIV virus to get into the CD4 positive T cell. What they're starting to find out is what's called delta 32 mutation of the CCR5 gene. If someone is homozygous for that mutation, it is very, very unlikely that their CD4 positive T cells will be infected by the HIV virus. Even if somebody has one abnormal copy of the Delta 32 CCR5 gene mutation, they're a lot less likely than someone who doesn't have the gene mutation. So what they're looking at too is the drugs to block CCR5, and you would think, well, if we block CCR5, the co-receptor, will the CD4 T cell not be as functional? Will it depress someone's immune system? And that's not the case. Someone who has those mutations where CCR5 is not functional, well, the HIV virus is not only less likely to invade the CD4 T cell, but they still are very healthy. Their immune system does not seem to be depressed. That's very, very important for drug treatment. Talked about the NRTIs, the mechanism of action, the protease inhibitors. So the spectrum of HIV complications from the HIV virus itself, especially the GI tract, especially heart, especially muscle. Why? Because it's affecting the mitochondria. So not only is the HIV virus affecting the GI tract and the mitochondria, but HAART, your highly active antiretroviral therapy, greatly affects the mitochondria. That's why we see the polyneuropathy. That's why we see the cardiac problems and your cardiovascular issues. We got our endocrine issues with vitamin D deficiency, thyroid disease, insulin resistance. That's why a lot of the treatments we know, like chromium, magnesium, can be very, very effective for insulin resistance and these complications of the HIV virus. Hyperlipidemia, lactic acidosis. Again, why? Because we're disrupting mitochondrial function. Always go back to that. Why do we have polyneuropathy? Why are they having the cardiovascular issues? It's because we're disrupting mitochondria, especially with antiretroviral therapy. And especially, which I'll go into later, especially the GI tract. We see things like malabsorption, we see diarrhea. They're in a hypermetabolic state as it is. So they're losing a lot of nutrients. And I want you to think, as I'm going through this, the pathology of HIV, the pathology of HAART, think of your naturopathic therapies because they're very, very powerful. And it's what patients aren't necessarily getting if they're just on antiretroviral therapy. You will see that they do need the integration. They do need our therapies, which you know can heal the GI tract, whether that's nutrition, botanical medicine, the mitochondrial support, I'll go through that, but whether it's CoQ10, L-carnitine, magnesium, omega-3 fatty acids, D-ribose, a lot of nutrients and a lot of therapies that we have can affect these complications. Talked about cardiovascular, the skeletal, the muscle. They see a lot of osteoporosis, osteopenia, a lot of fractures with it, again, because of the hypermetabolic state, because of the chronic inflammation, because of the HIV virus itself. Stages of HIV infection, I have this on here. We have acute infection, clinical latency, and then we eventually have AIDS, which is anytime you get below 200 cells of your CD4 positive T cells. The reason I have that up there is because poor nutrition and severe stress are huge implications of the time from that clinical latency to full-blown AIDS. And again, think of your therapies, think of what we can do as far as nutrition and reducing stress. Here's a research article, and again, people ask me all the time, I'll talk to medical doctors about these things and what we do and what I do as a naturopathic physician. And everything is, where is the research, where's the research, where's the research? The research is there. Just find it, show it to anybody who asks, but it is there. Vitamin D and calcium can lessen the bone loss, osteoporosis, osteopenia that we see. As soon as they initiate antiretroviral therapy, we see a 2 to 6% loss of bone mineral density. Another research article. So here's a research article on CoQ10. Again, as I told you before, your NRTIs, your nucleoside reverse transcriptase inhibitors, not only do they prevent the viral RNA from becoming viral DNA, they also disrupt the mitochondrial polymerase, which we need for the electron transport chain, oxidative phosphorylation. These drugs, your NRTIs, they greatly disrupt mitochondrial function. And here is a lot of research that shows CoQ10 can negate those effects. And of course, we know I give another lecture on chronic fatigue. And I literally just take people back. I give it to nurses all the time. And I show them what we're talking about here. Because a lot of people say to me, I really believe in your medicine. I believe in what you're doing. I said, you don't have to believe in it. It's biochemistry, it's physiology. CoQ10 is part of the electron transport chain. It's part of oxidative phosphorylation that produces ATP. You must have that for energy. If you don't have enough CoQ10, you're going to get muscle pain, you're going to get fatigue. Again, always go back to your physiology, always go back to your biochemistry. Lastly, we have a lot of research to back it up. Here's a research article talking about acetyl L-carnitine. I talked about L-carnitine. Again, back to our biochemistry. We got to have L-carnitine to take the fatty acids into the mitochondrial membrane to produce energy. Acetyl L-carnitine has the acetyl group attached. Very, very powerful at helping not only do the NRTIs affect the mitochondria, whether it's the heart muscle, whether it's skeletal muscle, they're going to affect the mitochondria and the neurons also. We see a lot of polyneuropathy when someone starts antiretroviral therapy. Here's research showing that acetyl L-carnitine, not only does it help with symptoms, it actually helps regenerate the neurons to help with the polyneuropathy. Very powerful. And the dosage here was 1.5 grams twice daily. So we have depletion of nutrients from HIV pathogenesis. Why? We got oxidation. Again, I talked about mitochondrial DNA damage. I'll talk more about enterocyte destruction in the GI tract. Here's just research talking about how a daily multivitamin helps with patients that have HIV and antiretroviral therapy. More research talking about negating the oxidative stress. Nutritional support. Not only is it shown to support the immune system, it's shown an increase in your CD4 positive T cells. And of course, that's what we want with HIV. We want to reduce the viral load, and we want to see an increase in the CD4 positive T cells. Again, I'm not saying that you don't need the antiretroviral therapy. That is absolutely essential and needed. But again, research article, time and time again, we'll see when this study was done with multivitamins, it delayed the time for antiretroviral therapy. Well, why would we want to delay the time when we start HAART? Well, because of all of the side effects. And there's countries where resources aren't very abundant. So if we can delay that time, it's a lower cost intervention, and you decrease the time for side effects. Again, nutritional support, it decreases inflammatory cytokines. In the GI tract, the problem is that we have the HIV virus and we have the antiretroviral therapy causing damage to the enterocytes. We know what happens there. We probably understand this mechanism more than anybody because we know the gut is the source of almost anything, especially chronic inflammation. When you damage those enterocytes, you get increased gut permeability, we get increased microbial translocation, and that increases chronic inflammation. The problem is the inflammation that is increased, it is dysfunctional. And we get a depletion of T cells. So that inflammation is macrophages, it's inflammatory cytokines, whether that's interleukin-6, tumor necrosis factor alpha. So we have the pro-inflammatory cytokines increasing and your T regulatory cells decreasing. So we get that chronic, constant inflammation that allows the HIV virus to persist. Nutritional support also gives hepatic protection, increased muscle mass, decreases HIV protection. So what can we do about oxidative stress? Again, think of your therapies, vitamins A, C, E, alpha-lipoic acid. Very, very powerful antioxidants. N-acetylcysteine, the precursor to glutathione. We know that's our most powerful endogenous antioxidant. But for absorption, we need it in the form of N-acetylcysteine. That's why we give it like that, unless glutathione is intravenous. But a lot of the studies that I've read is on N-acetylcysteine orally. Of course, selenium for immune function, very powerful. Cardiac support, I talked about this, L-carnitine, D-ribose, magnesium, CoQ10, your B-complex. Why? Because they're all part of biochemistry and physiology, like I talked about, for the production of ATP, protect the mitochondria. So GI support, think of your demulcents. I don't have them on here. Of course, your slipperyome, your marshmallow, your DGL, your L-glutamine, zinc carnosine, very important. Why L-glutamine? We know that that's the preferred fuel source for the enterocytes. Bone health, of course, vitamin D, magnesium, vitamin K2, calcium. Why vitamin K2? I tell patients all the time, like, well, I'm on vitamin D and calcium. Is that okay? I'm like, no, we want vitamin K2. The reason for that is research is showing We need vitamin K2 to direct that calcium away from the artery and into the bone. And vitamin K2 is shown to be essential for that process. So neuronal support, I talked about the acetyl-L-carnitine, of course our B complex, our B12, our folic acid, our omega-3 fatty acids. Immune support, we got selenium, zinc, vitamin A, vitamin D, glutamine. So are there interactions? Can there be problems with antiretroviral therapy and certain treatments that we have? Whether that be nutritional, botanical, yes there is. Vitamin C, 1,000 milligrams a day, was shown to decrease plasma concentrations of indinavir by up to 20%. Garlic, which we know is a very powerful antimicrobial, and you think that would be good against a virus like HIV, but it's been reported to decrease the bioavailability of sequinavir by 51%. So here's when I start talking about probiotics in the gastrointestinal tract. So important because 60% of our CD4 T cells are located in gut-associated lymphoid tissue. And of all tissue, that is the one most greatly effective with HIV pathogenesis. So what happens? I kind of went through this mechanism before, but the HIV virus itself and our antiretroviral therapy cause destruction to the enterocytes of the small intestine. This causes inflammation. This causes the microbial translocation, decreases CD4 positive T cell counts, and it allows the virus to replicate with that chronic inflammation. And we get the decrease in T regulatory cells, the increase in the inflammatory cytokines, tumor necrosis factor alpha, and interleukin 6. We see an increase in LPS, lipopolysaccharide, CD4 soluble CD4, and that's used by macrophages to attack LPS. So when we see increased levels of that, we know we have increased inflammation in the GI tract. So highly active antiretroviral therapy, while it does have side effects, is very, very important for decreasing especially viral load. And it does increase CD4 positive T cells. The thing is that's mainly in the periphery. It's not very good at affecting the CD4 cells and at stopping the virus from perpetuating in the gut-associated lymphoid tissue. And this is where support is greatly, greatly needed to stop that inflammation. And here's research talking about that. So GP120, the glycoprotein on the HIV virus, that causes direct destruction of the enterocytes itself. So again, we see increased intestinal permeability, increase in the pro-inflammatory cytokines. There's also a decrease in what is called CCL25, and what that is, that's a ligand on enterocytes, and that's like a homing device to draw in CD4 positive T cells, because we're losing the T cells in the GI tract. We need to increase it. We need to keep that population there. We need to restore it. So that's a problem. When we keep losing CCL25, we see that decrease in the small intestine of HIV-infected individuals because the enterocytes being destroyed. A lot of studies on probiotics. You'll see some research that says, well, if someone is severely, severely immunocompromised, what about bacteremia? What about sepsis? About this getting into the bloodstream? And most of the research that I found, that isn't a problem. They didn't see any side effects with the probiotics. They actually saw the opposite. They saw integrity reinforced to the tight junctions of the enterocytes. They saw chronic inflammation go down. They saw CD4 positive T cells increase, and they noticed the viral load going down. That is very important because, again, remember, HAART is not very effective at affecting the CD4 T cells in the GI tract. Again, decrease adhesion of pathogens, all the things that we know probiotics do. Decreasing the growth of pathogenic bacteria. And then one of the major things we talked about with HIV is we have our malabsorption, we have the diarrhea. So anytime we can increase digestion, absorption of nutrients, that's going to be very powerful. It's going to affect the immune system. It's going to take down inflammation. All the things that they do there. Here's a study. It had 4 groups, a probiotic group, a symbiotic group, a placebo group, and a prebiotic group. Symbiotic is just a probiotic and a prebiotic combined. What they found out with the probiotic group was everything I have listed there. Reduction of bacterial DNA in the plasma. They actually had an increase in bifidobacterium in the stool, a decrease in Clostridium in the stool. Like I said, increase in CD4 positive T cell count, and decrease again in the inflammatory cytokines. So again, the research is out there for these vitamins, these minerals, these probiotics. Here's another research article talking about affecting the intestinal microbiota. So what they found, is bifidobacteria, lactobacillus, those were decreased, but things like Pseudomonas and Candida were increased. Another randomized, placebo-controlled randomized trial talking about HAART. But, one of the main things that I came across is that everything that highly active antiretroviral therapy does and how it does benefit, it says it doesn't have a solution to the damage that's done to the GI tract. And that really resonated with me. It showed me that integration is needed. We see, like the Cancer Treatment Centers of America, we see that integration with oncology. And if you look up the University of California at San Francisco, they have one of the top HIV/AIDS hospitals in the country. And I was researching that hospital because they seem so integrated. So they have cancer, oncology integration, almost anything you can think of. Again, one of the top HIV/AIDS hospitals in the country. They have one of the biggest integrated hospitals there are. But there wasn't the integration for HIV and AIDS. And I didn't understand that. And I'm still looking for it. If anybody goes into that when they graduate, you're interested in it, give me a call, because I think there needs to be more integration. Because like I said, the highly active antiretroviral therapy is very, very needed. But our therapies are also very, very needed at the same time. So what is a proposed solution? Well, I propose the integration of what we do, a naturopathic physician, an HIV specialist, for the macronutrients, the micronutrients, probiotics, which I have as the HTCA, HIV Treatment Centers of America. There are the references. We are a little early, so I can go back and review anything that anybody wants reviewed or has any questions. Anything anybody would like to go over or review? Yeah.
A lot of individuals with HIV or AIDS are in a low socioeconomic population who can't necessarily afford these supplements. We do have an HIV clinic in Danbury, and oftentimes we're struggling to just give them basics of a multivitamin and things like that.
Yeah.
So what do you propose nutritionally to support these people when supplements is not viable for them?
In some of these studies with the multivitamin or even probiotics were done like in third world countries, believe it or not. A lot of times it was a yogurt that they would do, and they would ferment, and they would get the good bacteria. And they talked about that. They talked about those challenges where they had to keep things cold. They made these special kitchens where they did make this special. It was some kind of fermented dairy product. And they were able to do it, to produce the bacteria, and it was low cost. It took a lot to get there, but they did do it. And then the multivitamins and minerals, they talk a lot of times about that being a low cost intervention. So I think it would be, what can we do at the most basic level? Which would be a probiotic in the form of most likely food for what you're talking about, as low cost as we can, but still proven to have high levels of the good bacteria. That is going to help the GI tract, that is going to affect the immune system. You have places like Vitamin Angels, they're really good. And I know a lot of supplement companies that a lot of their proceeds will go towards organizations like that, especially for like vitamin A deficiency and blindness in third world countries. And so they'll donate. So things like that. And that's a lot of where the work needs to be done, because that's one of the concerns that I have. This is great, you're exactly right, but we talk about all the things that we have. It is very, very powerful, but it can get expensive. So that is another route that needs to be looked into. But they are finding solutions. A lot more needs to be done. Great question. Yeah?
Sorry, could you review again the pathogenesis of HIV in the GI tract?
Absolutely. So if we just think about where the majority of the CD4 positive T cells are, they are in that gut-associated lymphoid tissue. Okay, so that's where most of them are going to be. And again, with HIV, that's where the virus is attacking the most too, is at the level of the gut-associated lymphoid tissue. And it's that destruction. Like I said, even the GP120 on the HIV virus, that glycoprotein itself causes damage to the enterocyte. Now again, that's going to cause, anytime we have disruption of those tight junctions, that's going to cause increased intestinal permeability. From the microbes in the GI tract, and a lot of these HIV patients, they have a majority of pathogenic bacteria already. So we get that microbial translocation, that's going to increase the inflammation. Not necessarily from the CD4 positive T cells, because they're being invaded, they're being depleted, they're being destroyed. But macrophages, dendritic cells, they're being activated, they're secreting the inflammatory cytokines, again, whether that's TNF-alpha, whether that's interleukin-6, and that's causing our chronic inflammation. This chronic inflammation, though, you know, it's disrupted, it's dysfunctional. It's not helping protecting us from the HIV virus. It's almost weakened, even though it's chronic inflammation. This is actually causing the HIV virus to persist and to replicate even more. The problem is the highly active antiretroviral therapy is very effective, again, at restoring the CD4 T cells in the periphery, reducing the viral load, but it's just not as effective, again, in the GI tract. Does that help?
Mm-hmm.
Yeah.
I wasn't quite clear in the mechanism for the destruction of the mitochondria by the proteases or the HAART.
The main antiretroviral therapy drug that affects the mitochondria is the NRTIs, the nucleoside reverse transcriptase inhibitors. Affect this. Because they are affecting reverse transcriptase, so our NRTIs, nucleoside reverse transcriptase inhibitors, they're directly inhibiting reverse transcriptase, which is the viral enzyme that makes the viral RNA to viral DNA. But they also inhibit DNA polymerase in mitochondria. So the mitochondria can't keep producing or replicating. So we get dysfunction of the mitochondria. I mean, it disrupts the electron transport chain, oxidative phosphorylation. You know, we're not producing ATP, but it's destroying the mitochondria. Those NRTIs is destroying the mitochondria directly and causing dysfunction. So that's, again, why we get our cardiac problems. We get we get conduction problems. We have increased atherogenesis. Again, the polyneuropathy. And that is directly from those NRTIs.
It's just weird because, I mean, there is no reverse transcriptase mechanism in the mitochondria. It's like mitochondrial DNA.
It is stopping DNA polymerase in the mitochondria. So it's inhibiting that, just like with the NRTI. It inhibits actually reverse transcriptase, I'm sorry. So the NRTI is inhibiting reverse transcriptase, then it also inhibits DNA polymerase in the mitochondria. And again, stopping its reproduction. Any other questions or anything else want me to review more of? I hope you guys are really encouraged by it. Is anybody encouraged by your therapies even being able to affect HIV? Because I know when I was studying the HIV virus, I'm thinking, you know, it used to be a death sentence. You know, highly active antiretroviral therapy has increased the lifespan. But what necessarily isn't happening is the quality of life. That's where we can really come in. we can really support the side effects, not only the HIV virus itself, but from the treatment that is needed. I mean, this is one area that I think is definitely, we need the integration. You know, there are some things that we can look at and be like, an autoimmune disease, I can do that. You know, we don't need any, don't get in my way. You know, I'm gonna handle this, we're gonna do great. But with this virus, I definitely think we need more integration. And that's why all this research is important, because it is out there. The research is there, and most people aren't doing it. So if we do it, and we can convince other people that it's needed, and what we do is very, very powerful, even with something, you know, as harsh as HIV and AIDS, we can have an effect. Our therapies can have a very, very powerful effect. I think there was a question about.
No, you just asked if anybody excited. I said, yeah.
Oh, great. Good to see that. Thank you. Yeah.
I have a question. So while there's a large amount of damage done to the gall tissue,
Yeah.
and then in the cases where there's advanced HIV or AIDS, is there any kind of naturopathic therapy to induce, say, progenitor cell production of T cells within the bone marrow?
Nothing I've come across as far as progenitor cells, you know, creating. You're talking about new CD4 T cells to repopulate the gall? Yeah, I haven't come across that. If you do, please let me know. We need to add that to the lecture, because that will be. But again, we know how powerful our therapies are, and they can affect a lot. Again, at the most basic level. Yeah.
Is there any chance you could have these slides sent out to us? There's a lot of good evolution research in here that I'd like to get on my own.
Okay. Sure. I'll have to. Yeah. Have somebody do it. But we're recording it too.
Yeah.
Good. I think there was another question. Okay. No more questions, no more feedback? Guess that's it. Thank you guys for your time. Thank you.